are the twin killer enemies. The mortality due to hypertension and high blood sugar, if you see, it's multiplicative. Go back, please. 10 selected risk factors for cause of death. Top on the list is blood pressure. Just like diabetes, it's also a silent killer. See, tobacco use comes next. That's why I was telling all the time, cessation of tobacco is very important. Third is diabetes. And when these two go hand in hand, when they occur together, it's very important that both are controlled simultaneously, effectively. And it's not that we only control the blood pressure, only control the blood sugar. And if the patient has any and above all this is all-cause death, not cardiovascular death. So we are at risk of not only cardiovascular death, we are at risk of all-cause death. It's very important that we have this slide in mind. High blood pressure, the prevalence is something like 28% world over. So out of 6.5 billion in the world, nearly 2.8 billion hypertensives are there. Next, please. We know about this slide, would have seen in different fora. Top 10 countries in number of adults with diabetes, as goes the population. China tops, we are not far behind. By 2020, we are probably going to overtake China as far as diabetes is concerned. But you see the health related expenditure as far as diabetes is concerned, we are not in the list because there is no awareness in this country. Next. So that many Indians are going to be diabetics. 12.5 crore, 10% of our population. Next. So we have an India-specific study called the SITE study, where prevalence of these twin killers in urban settings was seen. We don't know what happens in the rural setup. We have no clue what happens in the urban setup as well. But we see the average prevalence, the two, when somebody has diabetes and hypertension, is something around 20%. Very high. Next. We know this slide, different ways we have studied. We have microvascular, we have macrovascular complications. I have told about this. More heart disease. We have so many individuals with hypertension across the globe. 80% of diabetics have concomitant hypertension. Diabetics are 2 times more likely to develop hypertension. And more stroke, more peripheral vascular disease, more cardiovascular disease. Hypertension and diabetes, you don't need any more unfavorable combination. Next. So how are these two linked? That's very important to understand the pathophysiology, because this is very important to our country. We have more insulin resistance diabetes. Leads to smooth muscle cell proliferation, vasoconstriction, increased sympathetic outflow, increased cardiac output and hypertension. Unfavorable effect on the kidney, leads to sodium and water absorption, reabsorption rather, and all this predisposed to hypertension. So we don't just treat the hypertension directly, we see how we can attack or target the therapy of hypertension at various levels. Again, let me reiterate, 75% of adults with diabetes have blood pressure above 130/80. That's normal for a non-diabetic, but when he is a diabetic, that is what is the blood pressure we have to aim for, less than 130/80. Diabetes and hypertension together increases cardiovascular risk by 3-4. If I see 100 acute MIs, 80 will have diabetes and hypertension together. 7-fold mortality increase when hypertension is present along with diabetes. Diabetes alone, less mortality. Hypertension alone, less mortality. Together, that is the problem. importantly, if somebody is hypertensive, with time, there is a 2.5 times higher risk of him becoming a diabetic. That's also very important to bear in mind. It's not only the diastolic blood pressure as we've been taught in medical school, systolic hypertension is very important as well. We see that the cardiovascular mortality rises very high once the systolic blood pressure crosses 160. Nowadays, for classification of hypertension, whenever the blood pressure is 160 by 100 or more, it is called stage 3 hypertension. That's because of this slide. The mortality is higher. When we say mortality, it's not cardiac mortality, it is cardiovascular mortality, which involves stroke as well. Very important as far as diabetics and hypertensives are concerned, it is inherently more difficult to control. If I see difficult to control hypertension or resistant hypertension, almost all will be diabetic. They may have other problems, but most of them will be diabetics. Next. Because they are going to be poor compliance. Let's not forget they will be on multiple drugs. Next. There is intense activation of the renin-angiotensin system. Already vascular damage due to diabetes. If obese, most often sleep apnea. Volume overload, especially if there is a concomitant nephropathy with diabetes. Next. So this control of blood pressure in diabetes is very important because the cardiovascular disease is very high. A diabetic has no other mode of end of life. No malignancy, no road traffic accident. It is cardiovascular event. Stroke, peripheral vascular disease, retinopathy, nephropathy, neuropathy. If we have complications of diabetes, which is going to be there in long-standing diabetes, we are looking at a cardiovascular event sometime in life beyond 10 years of diabetes. Reducing blood pressure is quintessential in management of diabetes with hypertension because every 10 millimeter fall in systolic blood pressure leads to lesser complications with diabetes, lesser deaths due to diabetes, lesser MIs, lesser microvascular complications. So it's very, very important that we don't treat the diabetes alone. When we have a diabetic, we get the blood pressure to less than 130/80, no matter how we do it. Next. There are a lot of guidelines, too much confusion. With a non-hypertensive, non-diabetic, so many guidelines, goal blood pressure less than 140/90, somebody says 130/80 and all that. But when it is a diabetic, it is less than 130/80 for blood pressure control. Next. What is the choice of therapy? Again, there will be a lot of confusion in this. There will be one small slide which shows very clearly what has to be done. The Joint National Commission, the 8, which lays the foundation for hypertension guidelines across the world, says thiazide type diuretic or calcium channel blockers in blacks, because blacks are non-responsive to ACE inhibitors and ARBs with diabetes. But if it is a non-black, always it should be an ACE inhibitor or an ARB. Next, please. And that's the very important slide. Only the solid line is the preferred combination. You initiate one drug, the blood pressure doesn't get controlled, you add on another drug. So it could be a thiazide with an ACE inhibitor, thiazide with an ARB, thiazide with a calcium channel blocker. It could be a calcium channel blocker with an ACE, calcium channel blocker with an ARB. No to beta blocker or antihypertensives, these dashed lines are not the preferred combinations. So very, very easy to understand. A, B, C or D. Next. We have to measure the blood pressure at every clinic visit. If it is a non-diabetic, our goal is to get it less than 140/90 and 130/80 whenever the patient is younger, albuminuric, additional cardiovascular risk factor in the form of diabetes. Lifestyle intervention I've already spoken about. Pharmacotherapy should always involve as ACE inhibitor or ARB because they are the only drugs which are vasculoprotective. Next. Next. So lifestyle modification is very important. Every time when the patient comes, we have to talk to them because a loss in kilogram of weight gets the blood pressure down actually by 2/1, 2 millimeter systolic and 1 millimeter diastolic. Next, less salt gets it down by 5/3. The so-called high protein diet 11/5. Increase in plant protein alone 8/4. less ethanol 4/2, brisk walking 5/4. If I do all this, I am getting down the blood pressure by 30/20. You may not even need a drug. That's why I said in the beginning, the previous talk, that whenever the patient is given a medication, is not responding to therapy, you prevail upon the need for a lifestyle modification, the same drugs start acting better. Next. So why it is important? Because physical activity and sedentary lifestyle in diabetes has a very, very bad effect on the vascular system. In the NHS, when they conducted the survey in England, they found that just TV watching 2 hours a day increases the risk of diabetes by 14%. Just sit and watch TV for 2 hours, not doing any work, just being sedentary. However, you do brisk walking 1 hour a day. That's why I repeatedly keep shouting about walk, walk and walk. That less is the incidence of diabetes. Next. How do we control this deadly duo? Screen and treat if there is any underlying depression. Very important, because that's when the compliance of drugs gets better. Educate the patient all the time about the goal blood pressure, what you wish to achieve. Use simple drugs which are cheap so that the patient doesn't default. Go for fixed dose combinations. When you need more than 2 drugs, try to combine the drugs so that their compliance improves. Always look and address for side effects all the time. If there is troublesome pedal edema, weight gain, switch over from the calcium channel blocker. Every visit, we have to ensure that the patient is adherent to the drugs. There is something called therapeutic inertia on the part of clinician. We are happy with 140/90 or 150/90. It may not have any effect as far as the patient's symptoms are concerned, but then long term it is not good for the cardiovascular system. Patient has hypertension and diabetes, that is a target, less than 130/80, shown and proven in most trials now. Next. So how would I treat? My goal in diabetic who needs treatment for blood pressure is 130/80. In this part of the world, no problem as far as black and non-black is concerned. I initiate ACE inhibitor or ARB. If not at goal, I add other drugs, one after the other, for the preferred rational combination. It could be a thiazide, A plus B, A plus C, or A plus D. A, B, C, D. That's all the 4 drugs. Next. So there are some Indian guidelines which have been laid. It's got published in our JAPI. ARB or ACE, not at control, add B or C or D. Not at control, add all together. A, B, C, D. Not at control, you can think of spironolactone every day or every other day. It's very simple, very, very simplified flow chart laid down by our physicians. Next. So newer insights are what is the effect of targeted blood pressure on cardiovascular events? When patient has diabetes and a blood pressure which is less than 80, we have less events. It's very clear. When the patient's diastolic blood pressure is 90, it is twice as high. So there's a 50% reduction in cardiac events when you get the diastolic blood pressure from 90 to 80 in diabetes. That's very important. That's where the evidence comes from. Next. So, as far as antihypertensive medications are concerned, as somebody raised a question the previous time around, what is the risk of new onset diabetes? We see more diabetics in hypertensives treated with diuretic and beta blocker than when they are treated on statins. We have problem. We have to forever watch for new onset diabetes when the patient is on a thiazide type diuretic or is on a beta blocker for long term. That is one of the main reasons why beta blocker has lost favor as far as first line antihypertensive medication is concerned. Next please. What do the clinical studies reflect? So many studies published in diabetes care, increase in new onset diabetes. If you see thiazide or beta blocker or thiazide, all the time the risk is very high. Risk is minuscule with statins. Very, very important. These 2 drugs, which are the common drugs, for treatment of hypertension and cardiovascular disease, they have clear-cut evidence of new onset diabetes next. So cardiovascular event rates are definitely less when we treat the patients with diabetes, actively treat their blood pressure and diabetes together next. And so was the latest trial, the HOPE 3, HOPE 2 and HOPE 3. HOPE is the first trial which got published in 2000, 15 years ago. High risk of cardiac events, elderly patients, low EF or heart failure, they received ramipril 10 mg per day. MI, stroke, death and cardiovascular events are studied and significantly less in those patients who are treated on ramipril. Next. So the same thing, less revascularization, less diabetic related complications, less heart failure, less new onset of diabetes with the ACE inhibitor ramipril. Next. Unfortunately, it's a weak antihypertensive, so we don't prefer it as first line antihypertensive drug. Life study comparing losartan and atenolol followed for 4 years. What they looked for was cardiovascular events. Next, again, same thing, ARB better than a beta blocker. That's why the beta blockers are out now, because they do not have favorable effect on cardiovascular outcomes. Next. So when we have albumin in the urine, straight risk of cardiovascular events very high. Normal albumin, hardly any cardiovascular events. Macroproteinuria very high. There's only one cause of death in kidney disease with proteinuria. It's acute MR. They don't die ever of renal failure. That's the need, to get that protein down, get the blood pressure down. Next. We'll skip this please. Yeah, a very important trial called roadmap trial with olmesartan, where this microalbuminuria was targeted, and the microalbuminuria came down, but it did not reduce the cardiac events. That's very unfortunate, because we do not know the mechanism how it happened. Next. So I'll summarize by telling that hypertension and diabetes is a deadly combination. We have to manage it aggressively. Actually, it should have been bold. Delay in treatment of hypertension in diabetics can cause cardiovascular disease, chronic kidney disease, peripheral vascular disease, and strokes. Effective antihypertensive therapy should include optimal achievement of goal, glycemic and lipid control, and also inhibition of platelet aggregation. As I said earlier, aspirin is very important in these patients of diabetics with other risk factors. The guideline recommendation for blood pressure target in diabetics is different. You have to be more aggressive, 130/80 or less. ACE inhibition or ARB are the mainstay of therapy in diabetic and hypertensive. Plenty of studies have shown the efficacy of ARBs in hypertensive diabetics. I'll probably stop here and take questions if any, or go to the next one.
I should appreciate the person who thought about these common topics, really appealing to everyone, and also for choosing a person as Jaisankar to speak about this. The person really has volumes of experience handling this. Very clearly explained in detail about management of hypertension and risk factors related to cardiovascular diseases. So, before we move to the last part of the talk, I think can we have questions?
If you are not bored, we'll continue, or you want me to stop? Let's stop.
No, we'll continue.
What would be your target level for non-diabetic?
Well, we are supposed to treat, as Bala said the last time around, when the blood pressure is 140/90 or more, we start with lifestyle modification and then get the blood pressure down. Our aim is to get it to less than 140/90. But if it is diabetic, is less than 130/80.
Type 1 diabetes, younger individuals, drug of choice.
For
Type 1. For younger individuals.
BP,
with
for
type-
BP.
For hypertension, again ACE or ARB.
So diabetes with nephropathy,
ACE or ARB.
we can use
Yes, yes, yes. I'm sure you will enlighten us.
220%
Which antihypertensive should not be used in diabetic nephropathy?
Should not be used in
Yeah.
nephropathy.
I think, see, only thing is, theoretical first choice is obviously AC in ARB. Okay. Again, there are regimes and there are people who combine AC and ARP for maximizing the benefit. There is one trial which was called the on-target trial, which really gave a very bad thing about higher risk of hyperkalemia and cardiovascular deaths in combining AC and ARP. But our personal experience, Dr. Mani has published his own data. The problem in trial is you use fixed doses, you go by fixed regimes. So what we have been doing in the large volumes of CKD patients we see is, we start with small dose, we gradually up titrate the dose, monitor urea, creatinine and potassium, and we add on ARBs to ACE inhibitor after maximizing a dose. Honestly speaking, we have not had any life-threatening hyperkalemias, but the guidelines, the published guidelines have clearly mentioned don't combine AC and ARB. So if you ask our personal experience, which Dr. Mani has published it in various journals, we have not personally had any problem combining AC and ARBs. So to answer your questions, what will you not do is, if you go by the guidelines, don't combine AC and ARB. And number two is, there is a theoretical risk of worsening proteinuria if you use a calcium channel blocker. Because AC and ARBs reduce proteinuria, but calcium channel blockers cause afferent arteriolar dilatation. They increase the glomerular perfusion and increase proteinuria. But there is only a theoretical risk. As Jaisankar mentioned, ACE inhibitors per se are not fantastic antihypertensives. So they have a hypertensive control and also has other benefits of non-hemodynamically mediated benefits of slowing down the progression of CKD. So, but if the blood pressure is not well under control, definitely calcium channel blockers can be added.
Yeah, this is a new news for us because our nephrologist strongly advises not to use AC inhibitors or ARB in case of CKD, and instead they use
CKD,
that
that
is
is the drug of choice.
End stage can be used.
Even
They are
then,
talking about, see,
any stage of
see, only thing is you start, don't just let them go away. You have to you can start at whatever be the creatinine level. Only thing is you have to call them after a week or 2 weeks, just check for creatinine levels and potassium levels, check the blood pressure, and target blood pressure is less than 130/80. All diabetics and all proteinuric CKDs, the target of blood pressure is 130/80. Non-diabetic, non-proteinuric disease, the target is 149. And the drug of choice is ACE or ARB. And we don't mind combining ACE or ARB.
if you see the cardiac textbooks, what the question he just raised, what they say is, if the patient has underlying nephropathy, you have to monitor the creatinine very closely. If there is a 30% or more increase in creatinine from baseline, meaning normal creatinine for men less than 1.3 milligram per deciliter, if it increases by 30% after you start therapy, then you watch. Otherwise, you must continue. So up to 1.7, 1.8, I would not mind. If it goes beyond 2, then probably I think of taking. So if every